My name is Gopal Kulkarni. I am from Institute of Health Management, Panchod. So this institute is functional in Maharashtra state. So this is a around 50 years old organization working in public health. So institute has started their work way back in 1977 in Panchod. Panchod is a village which is under Aurangabad district, which is around 40 kilometers from Aurangabad. So what happened that in 1970s there was a very huge famine in that area. So a young doctor comes to Panchod and started public health interventions to address the issues related to malnutrition, anemia, maternal morbidity and mortality, and they have started their public health programs in the rural villages of Panchod. So this was the story. You can see our website, which is called at www.ihmp.org. So everything is given in that website. Okay. So after implementing the public health programs in rural in 1995, we have started our work in urban slums of Pune city. So uh, right now what we are doing that we are implementing programs for adolescent girls, young married women in 36 villages of Pachod and 100 slums of Pune city. So that is the current geographical area which we have covered. And our key domains are maternal health, neonatal health, child health, and adolescent health. So institute has their four main functions. So the first one is innovation. We are innovators. We do innovations in public health management systems. We are a training institute. We started our training institute around in 1984, and till date, more than 20,000 various government and non-government organization people who have got trained in terms of health management. So we do research for our programs also, and we also do undertake any formative research if there are any possibilities. So lastly, we are doing policy advocacy at each and every level. It does mean that from the grassroots level to state level to central level also. Generally, we used to share our experiences from our innovative programs, from training and from research. We try to disseminate those findings with the various policymakers at various levels. So these are the four key functions of the institute. Now, I would like to introduce exactly what we are doing in the area of reproductive and sexual health and family planning. So we are implementing these projects in, as I said, that 36 villages of Pachod and 100 slums of Pune city. So these are the interventions. The first interventions is health needs assessment and morbidity surveillance by health volunteers, or you can say ASHA workers. So we are all our interventions, we are very closely collaborating with government. So we do function with ASHA volunteers, and they, on a monthly basis, they visit each young married woman and assess their health and service needs. Most importantly, information needs and undertake morbidity surveillance. And this is being done using our Avni app. So they are using Avni app for the health need assessment and morbidity surveillance. And on a monthly basis, they visit each young married woman and assess their needs. This is the first interventions. Once they assess their needs, then from our digital app, we receive the data on microplans on the basis of needs identified during monthly home visits. So we use those data-driven microplans to link effectively all the clients who are in need to the service providers. So uh, so what happens that it improves access and utilization of health services, and we are receiving real-time data, so that real-time data-driven microplanning facilitate universal health coverage. So after the needs assessment, after assessment of information needs, we have had developed very good tools, behavior change communication tools. So using these tools, then ASHA workers and our functionaries provide need-based behavior change communication or interpersonal counseling to the beneficiaries. So ASHA identify information needs during their home visits using digital app, provide need-specific information and counseling to individual households, and the clients monitor their health behaviors. So the next intervention is linking of these clients to the primary level healthcare. ASHA actively links clients to outreach clinics and medical mobile units. In our urban slums, we have started medical mobile units. I will explain what they are and what all they are doing. So the active linkage with the MMUs and outreach clinics, and most importantly with urban primary health centers. So medical mobile units. So we have medical mobile units in our urban slums. These you can say these are the hospitals on wheels. So it includes a doctor, ANM, nurse, and a pathologist. So what happens that ASHA on a monthly basis does the home visits. And through those monthly home visits, she identified need of the young married woman, and she links those women, young married women, to these medical mobile units. So at medical mobile units, the patients are coming using the syndromic approach. So at medical mobile unit, our doctor again asks for symptoms, and if they feel that there is a need to do some diagnostics, then the pathology lab technicians are available. Then they provide the blood and sugar sample, blood and urine samples to the pathologist, and based on these two things, our doctor does the full diagnosis of that patient and provide the treatment. So these medical mobile units are functional in 100 slums. So this is one of the typical picture where doctor is examining the beneficiary, or you can say woman beneficiary. The last intervention is Mahila Arogya Samitis. In urban, in each slum, we have established Mahila Arogya Samitis. Uh, these were established as per the norms given under National Health Mission, and these are functional in all 100 slums. One of the key roles or responsibilities of this Mahila Arogya Samiti is they undertake community-based monitoring using the real-time data which we collected from Avni. It is very simple. They are monitoring how many people are in need of health services, whether these needs are addressed by the service providers or not. If there is any gap between these need and utilization, then they try to undertake the actions for addressing those gaps. So this is a simple way of community-based monitoring. And the last intervention is capacity building. So it is not possible for ashas or mass committees or our functionaries also without any cognitive and practical. It requires huge cognitive and practical skills to operate this digital app, to use very effectively, to provide referrals and everything. So one of the key overarching input is capacity building of all the people who are involved in this action. So we provide technical skills, behavior change communication skills, that is communication skills and management skills to Aisha volunteers, nurses, and other people who are implementing this program. So these are the five interventions we are implementing in both rural areas and urban slums of Pune city. And along with this, we are also working with uh, unmarried adolescent girls. So special but it has focused in rural areas. So in rural areas, 36 villages, we are implementing a program for unmarried adolescent girls, which is called as Life Skill Education Program. The key objective of this program is to delay the age at marriage and to continue to improve the schooling status of unmarried adolescent girls. So this is a 6 months program. Again, this class, the life skill education classes were taken by Asha volunteers. So these are twice in a week. They are implementing those, and they are covering 50 sessions. So this is a very brief introduction of this institute and the programs which are being implemented in the various geographies. Thank you.